Good afternoon, everyone. This case is of a 35-year-old female, and she is of 89 kg. So she had a long travel, and after that she developed left lower limb swelling, and she was diagnosed to have left lower limb pulmonary embolism and left lower limb DVT, and then later she had in her history she had CHAD S2 VAC score of 4 and Hasbled score of 1. She had also undergone PTCA2 LAD and inferior valve MI with 95% proximal lesion 22 months back. And her workup with CT venography or ultrasonography revealed May-Turner syndrome. And on echocardiography, it was shown that it is showing only mild PAH with bilateral subsegmental pulmonary embolism. So apart from standard medical therapy, we have two options, whether to go for catheter-directed thrombolysis or our standard oral anticoagulation with NOAC agents. So for the blue corner, we have catheter-directed thrombolysis talk by Dr. Kalpesh Hanswara sir. Yeah.
Anticoagulation, I'm going to.
Either here. Slide. So we have Dr. Anup Gupta, Senior Interventional Cardiologist, EP Specialist, friend of mine, ex-professor Michigan. He's going to talk about use of NOACs, and he's going to focus upon apixaban, how it's a therapy of choice in this case scenario.
Thank you very much, and thanks Kamal for inviting me again. So means I swept the talk with Kalpesh because I have to catch my flight. And obviously, it seems more appropriate, like, if you're talking about DOACs first, then the intervention and all the thing. So what I've been assigned to defend this afternoon is how we can manage venous thromboembolism, and which the lady has got a pulmonary embolism also, how we are going to manage those things. So coming to the case scenario, so does she need a thrombolysis? So I would say no for pulmonary embolism, because this is quite a stable pulmonary embolism. The hemodynamics are fine, mild pulmonary hypertension. We don't have the angina level troponin. What is the troponin level of NT-proBNP? Does she need DOACs? Yes, for atrial fibrillation, though atrial fibrillation could be as a part of pulmonary embolism as such, because see, 2 years down the line with coronary artery disease, she doesn't have any atrial fibrillation. This could be a part of pulmonary embolism. For DVT, yes, though the chances of post-thrombotic syndrome, and that is what we are worried about DVT, like post-thrombotic syndrome, swollen legs. Every time patient walks in a clinic and they complain like, my limb is still swollen. And it may work in presence of May-Turner syndrome, because what is the clinical scenario and what is the clinical situation? May-Turner syndrome, that's a common thing on the left lower limb. So if it is the left lower limb, what do you mean by May-Turner syndrome? It means the common iliac vein is getting compressed with the right iliac artery and D4 and D5 spine. So that is what is May-Turner syndrome. So what is the real world evidence? So always DVT, the immediate aim is to reduce the complication. So post-thrombotic syndrome, what I said is the most important thing, or the venous ulceration, the picture they were showing, like, again, venous ulceration. Thrombolysis definitely better, though it has got more bleeding complications, 6.7 versus 2.2 with anticoagulation or DOACs. Post-thrombotic syndrome is not like, if you give thrombolysis to each and every patient, there will be no post-thrombotic syndrome. 50% they still can get. Anticoagulation is 53. And when you're talking about thrombolysis, whether you're giving systemic or you're giving catheter-directed thrombolysis, the level of effectiveness remains more or less same. So what are the evidence of DOACs in venous thromboembolism? So two agents, rivaroxaban and apixaban, are commonly used. Both are comparable, although the risk of apixaban in bleeding is little less, and that is what the AF trial also showed. There is no head-to-head effectiveness trial and safety of the drug in the clinical practice. That is what probably down the line we'll come to know about this thing. Navasis, that he did what a propensity score matching cohort study for comparing apixaban versus rivaroxaban, 99 days, and what he found, recurrent VTE was, and major bleeding was more common in rivaroxaban in comparison to apixaban. So what he says that probably apixaban is much better, and it appeared to have a lower bleeding risk. So what are the recommendations right now? So DOACs definitely is preferred over vitamin K antagonists. So previously we used to give heparin infusion along with warfarin or acetylene, but now you can start DOACs. You don't have to give any heparin or any low molecular heparin. And what it say, like, it may not be appropriate for all the patient, And the panel does not suggest like, whether you want to give rivaroxaban versus apixaban. You can choose between two of them. If you see the meta-analysis of DOACs for the VT separate comparison with vitamin K antagonists, all the trials, if you're talking about apixaban or rivaroxaban, endoxaban, dabigatran, so if recurrent VT or death is much more less in DOACs rather than the vitamin K antagonist, major bleeding also was less. And if you compare here, apixaban definitely score over all other DOACs in major bleeding for sure. So what the safety says, apixaban is more safer and even with atrial fibrillation also. These are the two comparative trials going on, the CANVAS and the COBRA trial between rivaroxaban and apixaban, which the study will give you an answer what exactly it is, whether apixaban is better or rivaroxaban is better. And right now the evidence it's equal, like rivaroxaban and apixaban both are equal, and you have to judge clinically which one you really want to give. If you think the bleeding risk is high, you have to give apixaban. Amplify major bleeding or clinically significant bleeding with apixaban versus low molecular weight heparin. So if you see here, apixaban again score over enoxaparin and warfarin. Even the non-significant major bleedings are also good. Uterine bleeding, the difference was not significant between the two, though a little bit less with the DOACs. And coming to VT with apixaban versus the conventional therapy, that is what you give heparin and vitamin K antagonist, much superior, and major bleeding again, DOACs are much superior than the conventional therapy. Amplify extension, again, this was comparison with bleeding profile versus placebo, and if you see here, again, apixaban score much better than the placebo. What were the dose given for VT was 2.5. They have not studied 5 milligram twice daily, so we cannot say what will be the bleeding risk with 5 milligram twice a day, so we don't know about that thing. And the meta-analysis versus apixaban and rivaroxaban, again, apixaban score more over rivaroxaban in terms of all the events and in terms of major bleeding and clinical bleeding also risk. Apixaban is superior to rivaroxaban. So whenever you think like, patient is a young patient, bleeding risk or risk, you can think about rivaroxaban, otherwise give apixaban. So what are the recommendation for pulmonary embolism right now? So you give anticoagulation alone. So thrombolytic therapy in addition to anticoagulation versus anticoagulation alone. And if you see here again, the risks are very low and moderate. So it's not at a high risk. So you don't want to give in a subclinical pulmonary embolism, don't give thrombolysis. Probably anticoagulation is as good as thrombolysis. So you can consider thrombolysis if the relatively younger patient with a submassive pulmonary embolism, and should be closely monitored what is the hemodynamic status, what is the hemodynamic compromise. If suppose the blood pressure is less than 90 or there's a sudden drop of more than 40 millimeter mercury of systolic blood pressure, think about giving thrombolysis in those patients. So antiplatelet has got no role in DVTs. So this is what, again, this patient had undergone a angioplasty 2 years back. Probably she must be on antiplatelet. So again, this has not prevented the DVT. So don't give aspirin. So always give DOACs over aspirin. So how you can treat post-thrombotic syndrome? So one, people say that give stockings. So again, there's a two concept of theory, whether it's going to help or not. Thrombolysis may work, may not work. Again, it increases the chance of bleeding. So you start thinking about that thing. So if it is a May earner, they do mechanical thrombectomy. That's very useful. So stocking, again, stocking may still be considered for symptomatic relief in selected patient. Not all patients. Stocking doesn't really help. So what is the current status? So mechanical thrombectomy for iliofemoral DVT. This is associated with significantly lower Villalta score. So mechanical thrombectomy is the most important thing. Anticoagulation is again for the standard of care. And what the ATTRACT trial says, again, if it is whether you're giving a catheter-directed thrombolysis, adjuvant mechanical thrombectomy, that's must. Adjuvant mechanical thrombectomy, that's very important. Trial supporting anticoagulation, again, ATTRACT trial or a CAVA-20 trial or a CAVIN trial, what it says, anticoagulations are as good as thrombolysis. Only thing, iliofemoral DVTs, which are more proximal, secondary to methermer, probably mechanical thrombectomy may be better in these patients. What are the future trials? Randomized control trial between iliofemoral DVT using contemporary mechanical thrombectomy, anticoagulation is going to address the issue. This is again important, like clot retriever system comparison with Anticoagulation, that's again is going to be important. Other thing is what is the anticoagulation type, what are the compliance of the patient, whether the patient is taking or not. Ultrasound use, now peripheral ultrasound, IVUS is very, very important to see what exactly it is. Stenting again remain a further important thing. Coming to our case, what is May-Turner syndrome? So how do you diagnose? The most important thing is the CT venography or an MR angio, because ultrasound is not really good for proximal veins and they don't give you good collaterals. If you suppose it's totally occluded, they will not give you good collaterals. And CT and MR venography is 95% sensitive and specific. There are different types, like, the type 1 is the simplest to treat, focal compression. Type 2 and type 3 are difficult, even difficult for intervention radiologists also. And this classification has bearing on the treatment because the fibrotic one possesses real trouble. In the cath lab, I've seen people struggling to get the wire across the fibrotic part. So what is the recommendation right now? Lady with the May-Turner syndrome, DVT, acute DVT, which has produced a pulmonary embolism, has got an underlying coronary artery disease. So they should all be started with anticoagulation. IVC filter, no more recommended, should not be given. Pulmonary embolism risk are very, very low in May-Turner syndrome because there's a very stenotic lesion. So, the thrombus probably is not going to propagate into pulmonary arteries. And attractile, what it says, like, catheter-directed thrombolysis along with mechanical thrombectomy. That is the most important thing. And you have to really select those subgroup of patients of May-Turner syndrome where you really want to intervene as early as possible. I think I'll stop here. And my debate is going to take care by Kamal Sharma. Thank you very much.
Thank you, Anup. Chairpersons for the second talk. Second, can we have the display?
Good evening, everyone. Thank you, Dr. Kamal Sharma, for giving me opportunity to speak on the pulmonary embolism and DVT management. So there is no debate with Dr. Anup Gupta, sir. But we'll move parallelly, as sir said. The DVT and pulmonary embolisms are always treated as a adjuvant therapy. Always the patients need the oral anticoagulations for long-term therapy. So as we know the case scenario, this is 35 years female atrial fibrillations that already we have discussed. She's suffering from the May-Turner syndrome. So actually the best strategy would be catheter-directed thrombolysis adjuvant to oral anticoagulation in this given scenario. So what is a catheter-directed thrombolysis for proximal DVT, where we insert the catheter through the nearby venous access, will directly deliver tip of the catheter towards the clot and will give the infusion of the thrombolytic agent. So this targeted therapy. So in my case, which are the factors which favors the catheter-directed thrombolysis in this case? She is a young female, so patients who is having a DVT may suffer from the post-thrombotic syndrome, which is almost 50% rate if it is left untreated. Proximal DVT with pulmonary embolism, again, it's a favoring that you have to have a thrombolysis, either catheter-directed, or if patient having a massive pulmonary embolism, then it's systemic thrombolysis. Here in the case, it is subpulmonary sub-branches involved in pulmonary embolism. The head-split score is of 1. It is low risk for bleeding. Acute onset always treated as early as possible. And May-Turner syndrome itself, it's a risk for the clot formation because she is having a mechanical obstruction by the renal iliac vein. So catheter-directed thrombolysis is we know it's minimal invasive techniques. So all of the bleeding risk followed by this therapy is very less. It involves the placement of the catheter into the thrombus with delivering prolonged infusion of thrombolytic agent directly into the clot, which promises the targeted therapy with potentially reduce the systemic bleeding risk. It's most important in our case because the systemic thrombolysis, which though we don't do in the venous thrombosis, but it associates with the high bleeding risk when we do the systemic thrombolysis. So here the overall the systemic bleeding is very less as the drug is don't expose into the systemic circulations. And venous patency rate that has been found, it is higher if you treat CDT plus anticoagulations as compared to anticoagulation alone. So what are the indications? So when we have to use the CDT, we cannot use in all patients. As sir has said, there is a complications, bleeding risk, patient has to be put on the continuous infusion. So meticulous patient selections remains the cornerstone of the endovascular strategy in DVT and PE management. So first indication, patients with extensive thrombosis with high risk of pulmonary embolism. Second is acute proximal DVT. Third is threatened limb viability. When there is a life expectancy more than 1 year, recent onset of symptoms less than 14 days, and underlying predisposing anatomical anomaly like a May-Turner syndrome, and there is no contraindication of thrombolysis. So these are the all indications. Advantage of CDT, the lower rates of major serious bleeding like intracranial hemorrhage and retroperitoneal hematoma as compared to systemic thrombolysis, prevents a DVT recurrence, which is most important, because if patients will have a DVT recurrence, then again the chances of development of PTS is very high in these kind of patients. And higher patency rates improve the quality of life following the DVT. Why? Because it prevents the PTS, it prevents the valvular dysfunction, venous reflux, and long-term sequelae of the PTS. Not only CDT, but also, as sir has discussed, we can use the mechanical thrombectomy when it is needed. So initially patient is put on CDT and still the thrombus is not resolving. We can use the mechanical thrombectomy, as well as these patients having already have a pulmonary embolism. So we can put the vena cava filters at the same time during the CDT, because CDT will lead to the thrombus disintegration. That clot can be dislodged into the pulmonary artery, and again it will increase the load of the pulmonary embolism. So in this kind, we can prevent further thrombus dislodgement by putting the vena cava filters. Balloon dilatation and stenting can be done in patients with venous stenosis or venous compression, like in May-Turner syndrome following the CDT. So this is a case of May-Turner syndrome, which was treated with the CDT first. Then patient had a venous compression. So again, it has been treated with the stenting. As sir has discussed, post thrombotic syndrome, it is relatively common and highly significant sequelae of the DVT. 80% of symptomatic DVT patients are above the knee DVT will have a cumulative incidence of PTS almost 50% over the 2 years of the post DVT. Severe PTS reported in 50% of cases, leg ulcerations, 10% of patients, which leads to the reduced quality of life and disability. Venous infarction and compartment syndrome, limb loss also reported in some of cases. So this is a very significant issue if you don't treat the DVT, symptomatic DVT in patients with the high comorbidity. So comes to the trial. What are the trials? This was a large randomized landmark trial of Kevin, which was carried out by Enden in Norway, which involved the 210 patients as a long-term outcome after CDT with PTS as a primary outcome. And what they observed, that after 2 years, CDT had an absolute risk reduction for PTS almost 15%, which is a great number. And at the 5 years of follow-up, absolute risk reduction has gone up to the 28%. So over the period of time, this CDT in patients with symptomatic DVT will reduce the risk of the post-thrombotic syndrome. This is attractive, as already sir has discussed. They also studied CDT plus anticoagulation versus anticoagulation alone. This was the largest trial to the date, and they have studied almost 690 patients, and they have also used the PTS as a primary outcome, and they have concluded CDT is also safe, cost effective, and it improves the quality of life as a secondary outcome. This was a small trial which early randomized study was carried out in 2002. They used the local thrombolysis and anticoagulation in patients with iliofemoral DVT. They have studied only 35 eligible patients. The clot lysis and deep venous reflux were assessed with ultrasound, duplex, and plethysmography after 6 months. The result was drawn that at 6 months, patency rates was better in case treated with the thrombolysis, catheter-directed thrombolysis. And the venous reflux was higher in patients who has been treated with anticoagulant only. There was no major bleeding or death in this study. So catheter-directed thrombolysis in DVT with the use of reteplase, we can use the urokinase, reteplase, and alteplase. The doses are different as per the criteria. This was a study when 25 patients with acute or chronic DVT, and they received the reteplase with the infusion rate of 1 unit per hour in 5 patients and 0.5 unit per hour in remaining 20 patients. Then thrombolytic success was defined as a 95% thrombolysis with return of the antigrade flow. The result was the total dose of reteplase administered was 2.5 to 42 unit. The total infusion time ranged from the 0.3 to 84 hours. Thrombolytic success was achieved in 92% of patients. And endovascular stent placement or percutaneous transluminal angioplasty were required in 52% of patients to ensure the maintenance of the venous patency. So this is a comparison of urokinase, alteplase, and reteplase for CDT of in DVT. They have studied 74% of patients who underwent treatment for DVT. They were treated either with urokinase, alteplase, or reteplase with subtherapeutic dose of the heparin. And what they found, that all agents had a very successful venous patency rates, almost 97% to 100%. The infusion time on average was 30 to 40 hours. That is very good. So how will you start the CDT? So CDT protocol, the patient is identified. If on low molecular weight heparin, it says to stop for 8 hours, stop oral anticoagulant, let the INR comes less than 1.5, give 5,000 unfractioned heparin, start infusion unfractioned heparin 15 units per kg to maintain the APTT 1.2 to 1.7 times, take the venous access USD guided, introduce the catheter above the proximal thrombus and perform the venography. The dose of alteplase is 20 mg administered in 500 ml. The starting dose is 0.01 per mg per kg per hour. You can give up to the 20 milligram in a 24 hour. Observe the hemodynamic. Clotting study are performed daily basis. Maximum time of therapy should be less than 96 hours. Balloon angioplasty and venous stenting may perform if necessary. Catheter has been removed, then manual pressure is applied to control bleeding, and you start the LMWH and again establish the oral anticoagulation. So these are the CDT protocols. We know the contraindications. So whenever there is an absolute contraindication, we cannot use the thrombolytic agents. So now these days, newer devices, this is also available. This is ECOS device where they use the higher frequency, low energy ultrasound waves to assist the lysis of clot, thereby potentially minimizing the vascular damage and accelerate the clot lysis. Thank you.
So a third speaker has health issues, hasn't turned up. In his lieu, in the interest of time, I think I will not take that talk. But if I can have a couple of slides which I can show about rivaroxaban that he had prepared. Can I have the slides for rivaroxaban as the other therapy? Only advantage that it probably will have would be, so are we doing the quiz first? Okay, so let's go for the quiz first and then maybe I can show the slide on rivaroxaban, couple of slides. So the advantage that therapy with rivaroxaban would be, it's an OD therapy. So that's going to be the biggest advantage of it. The CDT is going to, the advantage of CDT is going to be reduction in post-thrombotic syndrome. So the quiz, of course, was this one. What is May-Thurner syndrome? Which artery crossing what is called as May-Thurner syndrome? Artery versus vein. So basically May-Thurner is compression of one of the artery with by one of the vein by one of the artery. So which artery compresses which vein to cause May-Thurner syndrome? That's the question. Can we have the question now? Meanwhile, we can have the discussion and inputs from the chair.
Sir, patient is a year old, past history, PTCA, and now having a DVD history of going thrombophilia state, means either inherited or acquired thrombophilia state. Or any thrombophilic state also. And another thing is if she pregnancy. To LMWH.
I think very beautifully pointed out that patient with recurrent venous and arterial thrombosis are more likely to be having thrombophilia, need to work on antiphospholipid syndrome, antithrombin 3 mutations, prothrombin gene mutation, hyperhomocystinemia. All these also need to be worked upon. But here May-Thurner is mentioned, so probably anatomical abnormality is probably the root cause. It is caused by right artery compressing the left vein. Not the left on the left or right on the right. It's the left common iliac vein which is compressed by the right artery. That was the right answer. Can we have the results? Again, this time I think Karthik and Khushi have already won. So Chirag is going to get the prize. Chirag, can I have the slides on? Rivaroxaban slide. I'll request one of the moderators to give prize. Janak bhai, to please come. That's the May-Thurner. And actually, this is the therapy. You'll have to actually put a stent. May-Thurner will require a stent. You cannot just end up on thrombolysis. But because if I was to say stenting, then there would have been no debate. We wanted a debate. That's why we put it like this. If it is not a May-Thurner, then both the choices are there. You want lesser amount. Venous stents have a very high occlusion rate. Plain balloon recurrence rate is 50% at 6 months. So, can I have my slides that Dr. Rahul was supposed to speak? I can just rush through them. So that Rivaroxaban is not non-represented here. Basically, Pioneer AF, if you're talking about atrial fibrillation, we know that the high CHA2DS2-VASc patients were most enrolled in Pioneer study. Pioneer was one trial where the CHA2DS2-VASc was highest. So if your patient is sickest and is most likely to have recurrent event, the data exists with Rivaroxaban. In CCS, you have a trial called AFIRE, which again concluded that atrial fibrillation stable CAD, Rivaroxaban versus Riva with antiplatelet was non-inferior. And the primary outcome of monotherapy was safer when compared to those who had remote PCI more than 2 years compared to those who had a recent one. This is another paper of AFib in CCS. Again, people are recommending. This scenario was created for Rivaroxaban in the sense that patient who have AFib plus CCS, chronic coronary syndrome with atrial fibrillation, the evidence is very strong for Rivaroxaban, not for Apixaban. Apixaban is still undergoing trial. And so if you're looking at overall picture and not just targeting the management of the deep vein thrombosis, in that case probably you will have to pitch in with Riva rather than apixaban. So that's my comment and the slide and representation for rivaroxaban. Open to panel discussion if there are any inputs.
Kamal sir, this is question to you only. We have lot of young females who come with the aortic valve replacement. Obviously, they are not going to be on NOACs. They would be on either warfarin or acetrom. They do go for the periods, right? So what's your take? Should they continue the warfarin or acinocumarol during the periods? Because either they have to maintain the INR. So that's a catch. Where what to do? They are in periods. They don't want to have a heavy bleed, but they are having either aortic valve or mitral valve replacement. You need anticoagulation.
Right. So I often say કે તમારા ઘરમાં જો નળમાં પાણી ટપકતું હોય તો વાંક પાણીનો નથી, નળ સરખા કરાવો. Which means if you have a bleeding, if you have your taps which are leaking, it's not the problem that the water is too thin, problem is with your tap. So if a patient bleeds, it actually means there is something else, an issue at the site from where the patient is bleeding. If patient has a menorrhagia, patient is on a VK or a NOAC or a VK is just bringing it out. Same is the case now we know from rivaroxaban study, where patients who presented with new onset of melena actually were more likely to be picked up with GI malignancy, which might otherwise not have been picked up. And we have real life cases. So it is like bringing out the hidden malignancies earlier rather than later. Most of these patients on VKA or NOACs who come with menorrhagia actually have DUB, or they have fibroids, or they have postmenopausal malignancy, which they've now started bleeding. So actually it brings it out. It's not an indication to stop, investigate what is the underlying cause, treat the same. But important thing would be, what about how do they treat it? So either they do balloon tamponading, that's what is common, because OC pills in such a scenario where there is already a thrombotic history will become a relative contraindication. So, or if you do a hysterectomy, if the patient is not planning another conception, or as is seen appropriate for the case.
So the take catheter directed.
So yes, so basically catheter directed thrombolysis is advisable for all major thrombosis above knee. Below knee, no advantage. Above knee, obstructives usually do better. High thrombus burdens do better. Already this patient had some pulmonary embolism, so he's at more risk. So a lot of times what we do is we put an IVC filter on top, then put a catheter, thrombolize, and then after 2 weeks of anticoagulation, remove the IVC filter. So this is what we commonly adopt. But anticoagulation versus CDT, evidences are very strong now for CDT. For high burden thrombosis, especially to prevent post-thrombotic syndrome, not to prevent other events or mortality. So later on, these patients, if you don't open up their veins, will come with collaterals, venous ulcer, pigmentation, heavy legs, bleeding, difficulty in walking, and maybe a risk of embolism, of course, stays unless you've taken rid of it.
Thank you. Thank you, Kamal.
All right, thank you. We can have a photograph and then we can move to the next session. Thank you, chairpersons and speakers.